Hi everyone, in this lecture I am going to deal about the management in third stage of labor. So from where the stage begin when the fetus is going to be expelled out, right? And once the placenta and their membrane, amnion and corona are also expelling out, this stage ends, right? So usually this stage takes 15 to 20 minutes in primary as well as multi-gravid women to complete if we are not giving any intervention and we are just waiting and watching to spontaneously expel out the placenta and their membrane. So this stage is although very crucial if you are comparing with the previous two stages, because it is not like that if the first and second stage is going well and there is no events are going to be take place, everything is all right, and this also goes normal, right? So this is very crucial one, because if we are not managed the stage properly, then there are more chances of bleeding in women, and this heavy bleeding can cause postpartum hemorrhage, right? So to manage this stage properly, there are the two methods. One is the expectant management, that is the traditional method, right? So one is the expectant management. So in this expectant management, we are not giving any intervention. We are just waiting and we are constantly watching to separate the placenta spontaneously and let the placenta to descend down in the vagina and comes out or expel out spontaneously, right? So with minimal intervention or without any intervention, we are just conducting this third stage of labor, right? That is called the expectant management. But the most routinely performed procedure or the management which we are using and which is also suggested by the WHO is the active management of third stage of labor. In short, we termed as AMTSL. So this AMTSL takes only 5 to 10 minutes to complete this whole stage, right? So by this you can see the duration is also reduced to half, because here this stage takes 15, this management takes 15 to 20 minutes to complete, but here it takes only 5 to 10 minutes to complete, right? So duration is also going to be just half, and the blood loss is also limited in this stage, right? So in this active stage of management, the WHO recommended various components, and there are the 4 components, and the 4 components in this active management are the use of uterotonics. First component is the use of uterotonics, and the another one is the delayed cord clamping. Delayed cord clamping. And the third component is the CCT, right? That is the controlled cord traction method, or also called as modified Brandt Andrews method, right? The third component is CCT, controlled cord traction, and the last component which is included in this active management is the postpartum vigilance. Postpartum vigilance. So these are the 4 components which were suggested by the WHO. So what comes in use of uterotonics? So uterotonics are the agents or the medication which we are using to maintain the tonicity of the uterus, because if the uterus become atonic, we won't be able to control the blood loss, right? So by the use of these uterotonics, which is one of the important component in out of all these 4, is very essential to control the blood loss in women, right? And this is very important to control the postpartum hemorrhage, right? So the drug of choice or the first line agent which we are using and which is completely safe for a woman is the oxytocin. So this oxytocin comes in various trade names like pitocin, syntocinon, right? So after 1 minute of delivery of baby only, we are just giving this medicine to a mother, and it is always should be intramuscularly, right? And 10 unit we are using. So never give this medicine IV bolus, or we can also give this in IV infusion as well, but never ever give this IV bolus, because this can cause hypotension in a woman, right? So initially it was like that, once the anterior shoulder releases or once the crowning of head occurs, we can give the medication, but the timing of the crowning and the anterior shoulder release and the expulsion of the fetus is so precise that at that time we cannot take any risk, right? So nowadays it is recommended that once the baby comes out and after 1 minute only we are using this oxytocin, okay? But the route of administration of this medication should always be intramuscular, right? We never ever give this medication IV bolus. But this oxytocin can only be preferred when the refrigeration or the cool chain storage facility is available, because this oxytocin requires 2 to 8 degrees centigrade for its storage, right? But if we are conducting this delivery in a rural area where the refrigeration is not available and we cannot maintain this cold chain, at that time the WHO also recommended the another drug which we can kept at room temperature and we can administer it orally, that is the misoprostol, right? We can give 600 microgram of misoprostol orally. So the most important component is the uterotonics use, because without these uterotonics that maintain the tonicity of the uterus, we cannot control the blood loss, okay? So the most preferred drug is oxytocin when the refrigeration is available, because this requires the cold storage, right? But the facilities are not available and we require room temperature medication only, then we can use misoprostol instead this oxytocin, right? So these are the drugs, but Methergin we are never using. Initially we are using, but nowadays it is not preferred, because it can cause one of the side effect of Methergin is hypertension. So if the woman is also hypertensive and if she is having cardiac diseases, we cannot use Methergin, right? So this is the safest drug in the uterotonics, that is the oxytocin, because it is contracting the uterus in the upper segment and it makes the lower segment progressively relax. So it is more convenient to expel the placenta out. Rather, if we are using Methergin that causes contraction in all of the direction of the uterus, that can cause the retention of placenta as well. So to avoid this retention and retain bits of placenta or retention of the placenta, we are using oxytocin. So the next component is the delayed cord clamping. So what delayed means? That we are not in hurry that once the baby comes out we immediately go and clamp the cord and cut in between. So this is not like that, because it is recommended by WHO that if we are delaying of about 1 minute or of about 3 minutes or until the cord pulsation ceases, that transfer good amount of blood from the placenta to the fetus, and it is around 80 to 100 ml, because the newborns are not getting enough nutrition through the breast milk, right? So delaying of cord clamping allows more iron from the mother to the fetus, and that can prevent anemia in the newborn babies, right? So that's why it is recommended nowadays that we can delay the cord clamping for about 1 to 3 minutes, or we can delay until the cord pulsation stops, right? So this is the second component, delaying of cord clamping to prevent from anemia. The third one is CCT, controlled cord traction, or the modified Brandt induced method. Modified because initially it was something else and now it is changed. So here there are the two terms, controlled as well as cord traction. They both means here. So cord traction, as the name suggests, what is happening in this technique? By this cord traction, the skilled birth attendants, because here it is suggested by WHO that this component only be performed when the skilled birth attendant is present, right? So all medical professionals are the skilled birth attendants. So once they are present, they can use their dominant or right hand to hold the clamp cord and pull the cord in a downward and backward direction, right? So the maternal end of the cord is pulled gently in this direction, right? That's called the cord traction. And what control stand here? Control means when the uterus is contracting, only at that time we can use cord pulling. It is not like that you can continuously pulling the cord, right? Once the uterus is contracting, at that time only you can pull the cord or give traction to the cord, right? So how can you assess that the uterus is contracting? So for the assessment, the skilled birth attendants can use the another hand and they can place their hand over the abdomen just suprapubically, or it is somewhere around in between the uterus upper segment or the lower segment. So by placing this palmar surface of the finger in between the upper and lower segment of the uterus, they can assess the tonicity of the uterus and they can feel that whether the uterus is contracting or not, whether the uterus is firm or not, right? So at that time only they can give traction to the cord. The another thing which they need to keep in mind, that with this hand, that is the hand which is placing over the abdomen, should be moved in upward as well as backward direction, because there is one of the another complication in this third stage of labor is the inversion of uterus. Because if we are not pushing this uterus in upward direction, that can cause the inversion of or the cupping of the fundus, that the fundus is invert inside, right? So to avoid this inversion of the uterus, we are using this pushing method, right? So with this hand which is placing over the abdomen, we are just moving the uterus in upward or backward direction, and simultaneously when the uterus is contracting, we are pulling the cord, right? So this is how we are using this technique, that is the modified Brandt Andrews technique, and this is only be performed when the skilled birth attendant is present, right? So this is the third component, CCT. Controlled. What is controlled here? Controlled is when the uterus is contracting, only at that time you can give cord traction, right? So this is the CCT. Now the last component is the postpartum vigilance, right? So once the placenta comes out, the fetal membranes also comes out. So you can use both the hands, and by the rotational movement you can keep this placenta in a sterile tray. If the fetal membranes are not able to release, then you can also use sponge holding forceps to release this fetal membrane. So after placing in a sterile tray, you can examine the placenta for their completeness. So you can examine both the surfaces like fetal and maternal surface and check out any missing cotyledones is there or not, or you can check out the umbilical cord for the number of arteries, that is the 2 arteries and 1 vein, and the fetal membranes are complete or not, or whether they are separable or not, amnion and chorion. So these all you can evaluate once the placenta comes out. So what comes in postpartum vigilance? See, once the placenta comes out, the uterus also contract continuously, because if the uterus is not contracting, the blood won't be able to stop, right? So we need to assess the tonicity of the uterus. The uterus is firm or not, and we just assess this tonicity in every 15 minutes for at least 2 hours. So that is called the postpartum vigilance. We are just monitoring the tonicity of the uterus in every 15 minutes for at least 2 hours is the postpartum vigilance. So with this tonicity only, the blood loss will be controlled, right? So this is called the AMTSL, that is the active management of third stage of labor. So this is the most preferred management because it takes only 5 to 10 minutes to complete, as well as this also controls the blood loss if we are comparing with the expectant management. So here we have seen how we can manage third stage of labor, and in expectant management there is only just waiting and watching policies there, and we are not intervening this as much, or we are just monitoring the separation, the signs of separation, and the descent and the expulsion of placenta, and finally examining the placenta. But here there are the 4 components in active management. That one is the use of uterotonics, that is the most common. The drug of choice is the oxytocin. The second one is delaying of cord clamping, delaying of at least 1 to 3 minutes. Controlled cord traction, that is with this uterine contraction only we are giving traction to the cord to expel out, and finally monitoring the tonicity of the uterus. Thank you.